All right. So nervous, endocrine, eyes and ears, 60,000 series. So you'll have, I think it's 6 questions on your exam that will include your 60,000. Let's just start out with number one. We have under general anesthesia, the provider excises the lower one-third portion of the right lobe of the thyroid, as well as the lower one-third of the left lobe. And then the isthmus is also removed. So the options that we have two that have 60210. And then we've got two that have 60212. So since those are right there next to each other, let's just go find those. So 60210 is for partial thyroid lobectomy, unilateral, with or without the isthmusectomy. And then 60212 is with contralateral subtotal lobectomy, including the isthmusectomy. So if we have the lower one-third portion of the right lobe, oh, where did all of my things go? Here we go. If we have the lower one-third portion of the right lobe, as well as the lower one-third portion of the left lobe, then if you look at your terminology that's in 60212, so 60212 is going to be contralateral, meaning opposite side. Contra means opposite, lateral means side, right? So if they are doing or they're doing a thyroidectomy, well, I guess a lobectomy, right? Because we're doing a third of the right lobe and then a third of the left lobe. That is going to be that contralateral or the opposite side as well. And then it also includes the isthmus. So the isthmusectomy is also done. So we should only report the 60212. If we were to do 60210 LTRT, then that's going to just kind of, I guess, over-report it per se. But then if we do 60212, then the unilateral lobectomy is, let's just say, the right lobe. And then the contralateral, the opposite side lobectomy for the left. And then we also did the isthmus. Any questions on that one? I know that term can be a little tricky. So when you see that term contralateral, I always have written in mine that contralateral is opposite side. Just that way, it's another visual reminder what that med term means. Okay. Let's look at number two. Patient is having a decompression of the nerve root involving two segments of the lumbar spine via a transpedicular approach. So we've got 263056 and 263030. Let's go look at the 63030 just because that comes first numerically. So 63030 is for a laminotomy with decompression of the nerve roots, including a partial facetectomy, foraminotomy, and or an excision of the herniated intervertebral disc. And it's one inner space done in the lumbar area. So we're doing a decompression. So is there a laminotomy that is being done? Are we, um, if we're not sure, we can go look at 63056. So let's go look at the 63056 and see which one might better describe. So 63056 is the transpedicular approach with decompression of your spinal cord, equina, and or nerve roots, single segment lumbar. And it's including the transfacet or lateral extraforaminal approach, and then a far lateral herniated intervertebral disc. So which ones do you guys think? Do we need the 63030 or the 56?
56, but there's two segments,
Okay, yep,
correct?
56. Okay. And then we have two segments. Yep, correct. So we should use the 57 as well, right? Is that what you're saying?
Yes.
Yep.
It's the add-on code.
Yep. Yep. The add-on code for the additional segment. Because if we were to only report the 56, then that would just be one segment. And then the 57 is going to report our second. Yep. Okay. Any other questions on that one? Number three, a patient with a status post lumbar puncture headache receives an epidural blood patch. The patient's venous blood is injected into the lumbar epidural space, and this blood forms a clot, sealing the leak of the leak of CSF from the lumbar puncture. So we've got two that have 62273. Let's go look at that. So 62273 is for an injection epidural of blood or clot patch. That's what we did, right? We're doing an epidural blood patch. And then let's go to our ICD-10 and decide, do we need G97-1 or G44? So G97-1 is other reaction to spinal and lumbar puncture. And then our inclusion notes are headache due to lumbar puncture or other reaction due to a lumbar puncture. And then the G44.1, that is just a vascular headache. So which one do you, the G97.1 or the 44.1? Yep, letter C. Yep, because it specifically states lumbar puncture headache. Yep. Okay, any questions on that one? Number four, Mrs. Marston slipped on ice last winter and fractured several lumbar vertebrae. Since then, she has required pain management therapy at her local hospital with an anesthesiologist. He performs a therapeutic injection of 5% Marcaine with a steroid Decadron, which is 16 milligrams, into the nerve located at the facet joint at levels L3, L4, and then L4, L5 on both sides at each level using fluoroscopic guidance. So we have two that have the same codes, 64493 and then 64494, right? So that to me is probably our code. So let's go look at it and see which one we should use. So 64493 is injection, diagnostic, or therapeutic agent, paravertebral facet joint with imaging guidance, and then it's lumbar or sacral, single level. And then 64494 is the second level. Okay. So I've got a bunch of, or not a bunch, but I've got a few in the chat that say letter B. So what makes you think, if you want to come off mute, what makes you think it should be B instead of C?
Well, for me, I feel like the reason why it's not C is because 64494 is a add-on, and the modifier 50 and 51. Normally, you don't add both modifiers to that.
Well, you can if it's appropriate,
So
but you
if
just can't use a 51 if it's an add-on code because all of our add-on
yeah,
codes are going to be automatically exempt.
right, and
Yep.
then you got your multiple procedures, and then it's bilateral procedure. So that's why I was like, no for that
Well, you can, depending on your code,
one. Uh-huh.
because you can do a bilateral procedure in conjunction with another procedure. So there's not
Mm-hmm.
anything that says that you cannot use a 50 with a 51. It's just a matter of you can't use the 51 with the add-on.
Add-on code. Okay.
Yep.
Got
Yep. Yep. So, and then also, if you look at that little chart over on the left-hand column next to the 64493, like in that first column, then if you do two levels injected bilaterally, so you go down to the row that says two levels injected bilaterally, and then it's in the lumbar sacral, so it's your third column, then that's telling you that it is 64493 with the 50, and then 64494 times 2 units for the bilateral component. Okay, so this one, especially when you're doing injections within the spine like this, make sure that you're paying attention to the ones that should have 50s and the ones that should be multiple units. If they are an add-on code, so the 64491, 92, 94, and 95, those should all have 2 units if it's done bilaterally. And then the parent codes, the 64490 and 93, those are the ones that if it's bilateral, you'll use modifier 50. Okay. Any questions on that one? Yeah. Number 5, our post-op diagnosis is carpal tunnel syndrome of the right wrist. The patient was brought to the operating room and sedated with anesthesia after sterile prepping and draping of the right hand, wrist, and arm. The patient's area of incision was infiltrated with xylocaine marcaine infiltration. An Esmark bandage was used to exsanguinate the right hand and wrist and used about the distal forearm as a tourniquet. A curvilinear incision was made on the palmar aspect of the right wrist. Dissection was carried out through the skin and subcutaneous tissue. Bleeding was controlled. The median nerve and its branches were identified, retracted, and protected at all times. The ligament was incised from proximal to distal. A thorough decompression was carried out, and then a neurolysis was carried out. The nerve was found to be flattened and ischemic underneath of the transverse carpal ligament, and the fascia was closed and the tourniquet was released. A dressing was applied and the patient was transferred to the recovery room. So, first and foremost, we can rule out 2 options because we did not perform this on the left wrist. So, without even opening our books, we can already rule out 2. Okay. So now we just need to know, do we need 64721 or 29848? So let's go look at the 64721. because we are in the 60,000 series. So that's not saying that it's a guarantee that it's always going to be our 60,000 code. But let's go look at that one first.
So on
And
the
you're,
test, if
I'm
you're
sorry.
in a series of codes,
hmm
will they give you one that it's in a different series?
It could be. Like, for instance, you could be in the integumentary system and there be a laceration, and they say that they only closed it with butterfly strips. And then we would know that we need to code that with the ENM code instead of the 10,000 series for the repair. So it's possible. They won't always put one in there, but it's possible that they could use that as a scenario.
Okay, thank you.
You're welcome. So 64721 is the neuroplasty and or transposition, and it's of the median nerve at the carpal tunnel. And then just for S's and G's, let's go look at the 29848. And that way we can see the difference in the codes. And then your 29848 is an endoscopy wrist surgical with the release of a transverse carpal ligament. So they're both for release of the carpal ligament. However, one is an endoscopic procedure, and then one is just a neuroplasty, so an open procedure. So yeah, we should go with the open procedure within the 60,000 series, the 64721. Okay. Any questions on that one? Okay. Number 6. So now
I
we're
don't,
gonna go.
oh,
Oh no.
I, it's no big deal. It's just, that's a lot of verbiage for one little code. You know what I
Mhm.
mean?
Yeah.
I was expecting it to have many codes with that.
When you have a scenario like this, okay, because this may show up on your case section, this may show up, this is kind of like a in between, right? It could possibly show up in the 60,000 series and not a case, depending on just kind of which exam you get. So if that's the case, go look at your codes first and then skim through. Like, we know that all the way down, at least through here, we don't really need to know any of this, right? This is all just telling us that they prepped and draped the patient and made an incision. This is really where the actual like procedure start. And then really it's only up to here, because then the closure and the tourniquet release and all of that. So really all of this that's not highlighted is not really pertinent. This is our only like 4 lines that are pertinent to the scenario. So when you're in testing, if you find yourself not comprehending what they're saying, go to your codes and find your codes first, look at your code descriptions, and then you'll be able to say, okay, these are the main terms I need to focus on and pull out when I'm reading them.
Okay, that makes sense. Thanks.
You're welcome. Absolutely. I know a lot of people stress out over the cases, and that's what I always tell a lot of people is, try to focus more on, because it's easier to remember 3 or 4 words from a code description than it is to remember all like 100 words of this when you're reading your codes to say which one did I actually do, right? So if you read your code description and then know what keywords to pick out as you're reading it, then you're going to go, okay, it's not endoscopic, right? So if we know it's not endoscopic, then we're not going to use the 29 code. It's an open procedure. And then, so just kind of, use them that way to kind of rule out too. Okay. So number
Got it.
6, we're going to move on to eyes. So Michael has a bilateral lazy eyes and undergoes strabismus surgery of the superior oblique muscle for both eyes. So which CPT code is reported? We have two that have 67318. So let's go take a look at that. So 67318 is your strabismus surgery, any procedure, superior oblique muscle. So superior oblique muscle. We know it is the 67318. So should we use a modifier 50 or not?
Yes, we're gonna use the modifier 50.
Yep, because it was bilaterally. Yep. Absolutely.
I have a question.
Yes, ma'am.
In my book, I have strabismus, but however you say that, means
Mhm.
cross-eyed. So
Mhm.
is cross-eyed the same as lazy eye?
Essentially, yeah.
Okay. All right.
Yeah.
Perfect.
Yeah. Strabismus, basically, it just means that your eyes aren't focused in the same, and they aren't focused on the same thing. So it could either be cross-eyed or it could be one is looking forward and one is kind of lazy and kind of going wherever. Yeah. Okay. Number 7, 65-year-old patient presents with ectropion of the right lower eyelid. Repair with tarsal wedge excision is performed for correction. Attention was then directed to the left eye, and the patient also has an ectropion of the left lower eyelid, which was repaired by suture repair. So we have two, actually, actually, before we even go look at codes, there's two that we can rule out. Any guesses before we go look at codes, which ones we can eliminate?
Right.
A and C,
Okay, why are we ruling out A and C?
because I'm looking at the modifier E4 for the
Yep.
lower eyelid.
Yep. When we're talking about eyelids, then we want to make sure we're using the E modifiers. If you can't remember which one is which at the beginning of the, or on the inside of your front cover of the book, your E1 is upper left, E2 is lower left, E3 is upper right, E4 is lower right. So when we're talking about eyelids, not the eyes, when we're talking about eyelids, we should use the E modifiers. Yep. Okay. So now let's go look at the 67916 first. So 67916 is for repair of an ectropion with an excision tarsal wedge. And then the 67923, which is a little bit under it, is the repair of an entropion. So which one should we use? The 1-6 or the 2-3? 1-6. Yep. So even though they're both for excision of tarsal wedge, don't just read the indented portion of the code. Make sure you're going to the parent code to make sure you're doing for the correct condition if it's listed there. Okay. Any questions on that one? Okay. Number 8, patient with a cyst-like mass on his left external auditory canal was visualized underneath the microscope. And then a microcup forceps was used to obtain a biopsy of tissue along the posterior superior canal wall. So we've got 2 that are close and 2 that are close. So let's go look at the 69100 and 105. 69100 is biopsy of the external ear. 69105 is biopsy of the external auditory canal. And then 40 and 45 are directly underneath it. So excision of exostenosis, I'm sorry, exostosis? Exostosis, external auditory canal. And then 69145 is excision of soft tissue lesion, external auditory canal. So for this, oh, go ahead.
Sorry. Can't we remove A and C because they're right?
Yep. Yep. I hadn't even gotten to the modifier in my brain yet. So, yep, you are correct. So then should it be the 05 or the 4?
It's gonna be B.
Yep. 69105 because it is the left external auditory canal. Yep. And then it's a biopsy and not a soft tissue lesion that they're removing. Yep. Okay. Any questions on that one? All right. Number 9, 2-year-old with bilateral chronic serous otitis media has ventilation tubes placed in her right and left ears using general anesthesia. So let's go look at 69433 because it's in 2. So 69433 is a tympanostomy requiring insertion of the ventilating tube, local or topical anesthesia. And then your 69436 is for tympanostomy requiring insertion of ventilating tube under general anesthesia. Okay, so Don says 69436. Are we going to use the modifier 50? Yep, because we did it bilaterally. And then we have that modifier or that parenthetical that says for bilateral procedures, report 69436 with your modifier 50. Okay. And then last but not least, number 10. This one's got a lot in it code-wise, but we can narrow it down fairly easy. So patient presents to the emergency room with a severely damaged eye. The injury was sustained when the patient was a passenger in a multi-car accident on the public highway. The patient sustained a large open lacerated wound to the left eye, and the posterior chamber was ruptured, and significant vitreous and some intraocular tissue was lost. The eyeball was not repairable and was removed en masse, and then a permanent implant was inserted, but not attached to the extraocular muscles. The patient was released with an occlusive eye patch. So before we even open our books, we can rule out 2 again. Any guesses?
A and D.
Okay, we're ruling out A and D or we're keeping A and D?
We're ruling out.
Because of the 7 characters, right?
Yes, the S and
Yep.
the D.
Yep. Okay. So then we just need to determine, is it 65103 or is it 65093? So 651. So 65103 B. Okay. 65103 is an enucleation of the eye with an implant. Muscle is not attached to the implant. And 65093 is an evisceration of ocular contents with an implant. Okay. So did we do the implant? That's the main question. No, sorry.
Yes.
They both have the implant. Sorry. I was thinking it's muscles not attached is what I was thinking the knot was. Okay. So we did the implant. Is it an evisceration or an enucleation?
Enucleation.
Okay. Enucleation. Yep, because we removed the eyeball. Yep. The eyeball was not removed or was not repairable, and then it was removed. So that's going to be considered an enucleation. And evisceration is only going to be when the intraocular contents are removed. So we should use the 65103. So even though you've got a whole lot of external, well, really you've got two external cause codes, right? But those external cause codes allowed us to eliminate two, and then we were able to use our CPT. So don't always think that external causes, because I know that's a very hard to grasp concept in coding your external causes, but you can use them with your 7 characters of your injuries to help rule out very quickly. And then if you're more comfortable with your CPT than with your external causes, then you can use your CPT to figure out the correct answer. Okay. Well, that's all I've got question-wise. Do you guys have anything you want to chat about? Any just general questions?
I don't even know what to ask.
All the questions, but you can't even narrow it down. Yeah. Okay. Well, if y'all don't have anything, I'm not just going to sit here and make you talk about anything. But I always like to, especially if we end early with questions, then make sure that you guys don't have anything that you want to chat about in general. But if you guys think of anything, especially Jennifer and Sarah, since I know you've got exams coming up in the next couple of days, don't hesitate to reach out. Shoot me an email, shoot me a message on Facebook, whatever it is, however you want to get in touch with me. And if you think of anything between now and test day. But if I don't talk to you, either one of you before, good luck, positive thoughts. You've got this. Just try to stay focused. Don't let your nerves get the best of you. I know the nerves are the hardest part, I think, because have either of you taken exams before? So do you know what to expect?
I've never taken like an
Me neither.
AAPC exam. No,
You haven't either, Sarah?
No.
Are you all doing them in person or online, like remote proctor?
in person.
Remote.
Okay. Remote, make sure that you have your webcam. Okay. Make sure that you have your ID that matches. Make sure your desk is clear, like all of those things.
Mhm.
Make sure if you have any external monitors or anything like that, you've got them covered up, all of that kind of stuff. Other than that, just try to sometimes the proctors are very easy to converse with, sometimes they're not. So just kind of just stay patient. Like as no matter what they throw at you, just kind of just do what they ask and don't get stressed over it. Because I know I've heard some horror stories, not saying everybody's is going to be that way, But they talk about how getting prepared to get the setup approved and things to be able to actually start the exam. A lot of people
Mm,
say that their nerves were already shot before they even got to the exam.
mm.
But if you run into any problems, then you said is yours
Sunday.
Sunday.
Hmm.
So, okay, yeah. I was gonna say AAPC won't be open on Sunday, but if you do run into issues, call them on Monday first thing,
Okay.
and report any issues that you have with them. Hopefully you won't, but just if you do, then don't hesitate to reach out to them with any of your concerns.
Okay. Thank you.
You're welcome. And then Jennifer, for yours on Monday in person, um, show up just a little bit early and plan on being there a little bit early because you never know what traffic and just everything is going to be like on Monday. You can bring all of your stuff in a bag or a backpack or whatever, so you don't have to carry it from your car to the building. And then they have little lockers that are there, and they'll give you a key, and you can put that key in your pocket. That way, it's obviously secure and things like that. If you want to carry your person there, I know whenever I went in, I just stuck my ID in my pocket and then left my purse and stuff at home. So that way it wasn't even in the car and I wasn't even worried about it. And then whenever I went to the locker, I just shoved my backpack and then my keys and stuff like that into the locker. And then you can take breaks for both of you guys, but it doesn't stop your clock. I'm sure you know that, but I always like to make sure that everybody knows that don't drink a ton of water ahead of time so that 3 hours into the exam, your bladder is about to explode. But drink enough water that you're not dehydrated and then you don't like lose concentration and all. It's like a fine line, right? Um, but yeah, just take it one question at a time. Don't freak out. I mean, if for some reason you don't pass, you do have a second chance. Sometimes you just have to work out those nerves in the first time, but just stay confident the day before your exam. Don't do a lot of studying, don't do a lot of cramming, because if you don't know it by the day before, you're not going to know it. I mean, it's as crazy as that sounds. But just take the day before and just whether it be spend the day with your family, do whatever if you need to go, to a spa, like do whatever it is that relaxes you so that you're not thinking about it and you're not like trying to cram the day before, just because it's gonna your brain fatigue is a real thing. And then if you kind of like try to shove too much in, then your brain's just gonna like freeze up. But other than that, I mean, that's really just kind of the general question or the general advice. Did that raise any questions for you guys as far as what
N-
to expect?
No, that was perfect. Thank you. Appreciate it.
You're welcome. Absolutely. Okay. Well, if you all do think of anything in the next couple of days, anybody in general, if you think of anything in the next couple of days, don't hesitate to reach out. But if not, then I will chat with you guys next week. And then good luck again, Jennifer and Sarah.
Thank you,
Thank
Tiffany.
you.
You're
Thank
very
you.
welcome. Y'all have a good night.
You too.
Thanks.